Hello, everyone, and welcome back. Today, I have the amazing and wonderful, and I'm not kidding, Susan Clinton with me. Welcome.
Hi, so glad to be here. Thanks for having me on.
I'm glad I finally snagged you.
Yes, we have tried this a couple of times. I'm glad we're finally here
Yeah.
together.
Yeah. Gosh, you guys, you're in for a treat today. We're going to talk about all kinds of fun things related to, as this season has gone, bringing awareness to, but working towards ending medical gaslighting in women's health and pelvic health. But first, let me introduce you to Dr. Susan Clinton. She is board certified in orthopedic and women's health physical therapy. She's a fellow of the American Academy of Orthopedic Manual Therapy and board certified health and wellness coach. She's an international instructor of post professional con ed in women's health, including GI issues in women, which we will dig into, ortho manual therapy, and business psychology. She worked as a part of traditional clinics for many years and then ventured out into co-ownership of a clinic that I had the good fortune of going to and teaching in several years ago now, what, like a decade or something?
No, it's been a long time, hasn't it?
Yeah, I know. It's
Time
like
flies so
sticking
fast.
on. Um, just being able to provide that kind of conventional PT medicine. And then moving on from that, she decided to start a new entrepreneurial journey, which I can't wait to learn more about because this has been a relatively recent evolution. So I can't wait to hear about it. Her passion is to help people learn, to empower people, to heal through movement and an integrated approach to healthcare because we're all different. We all have a unique story. No two cases are the same. And so Dr. Clinton's passion lies in helping you discover your story and find a solution to the challenges that you experience. She has a rich wealth of knowledge, and I'm so glad that she's here to share today. Welcome again.
Thank you. Thank you so
Yeah.
much.
I was thinking back. When it was the first time that we met, because it's foggy to me, actually. And then all of a sudden, we were working on a project together and then presenting at national conference and then stuff, right?
hmm
Do you remember the first time we met?
I think we met for the first time. We probably have known about each other for a while, but I think we physically met when you came to Pittsburgh to teach
Ah,
at
yeah,
Embody with Becky and I.
you're probably right.
hmm
I think it feels foggy for me because with the internet, you can meet someone, talk to them like kind of a roundabout way, for years and not ever see them in person.
Right.
I've had colleagues and friends like that for over a decade that we were just back and forth, tossing the ball, proverbial back and forth, online,
hmm
and then realize, wow, actually, we've never seen each other in person yet. I don't know if that's a good or a bad thing, but
Well, unfortunately, I think it's a thing because
it,
there's people I ran into at CSM this year that we were like, "Have we really ever met in person?" This is
okay, good.
wild to, like,
I'm
really
glad
get
you're
to see you in the flesh, not on a screen.
I'm glad you're saying that too. All right, so that's the first thing that I was wondering about. But second of all, you've made this incredible transition from being in a clinic of treating patients, doing the one-on-one thing, to now people can find you at ltiphysio.com. Is that right?
Mhm.
Okay, ltiphysio.com. We'll put that in the show notes. Tell us all about your evolution, like your story. I don't even know how you came into physical therapy. I certainly know how we ended up meeting at the clinic, but then this whole evolution towards where you are now, which I think really kind of mirrors where in many ways our profession is going and should be going.
Awesome. So, I came into physical therapy back in 1979 when I went to PT school when it was a Bachelor of Science degree. It was a 15-month program, which is crazy to think about. 18
Yes.
months, I guess, really, not 15, 18 months, whatever. It was short. And the avenues that were open in those years and days were working at a rehab center, working at a hospital, or if you wanted to, you could hang out your own shingle and do private practice. Insurance was generous in those days, and therapy was well paid for. So people did well in private practice back then, and didn't have, the burden of paperwork and some of the stuff that we have now. I stayed in acute care for a bit and went into a private practice and worked there for a little while. And then I moved to New Orleans and started work at a large rehab center there, which is it's still there, Turo, but it's things have changed in different ownerships and stuff like that. I worked in acute care, but then I moved upstairs to the rehab ward, and there I spent many years working with clients who had brain injuries of all kinds and spinal cord injuries. So anything neurological ended up on the rehab units. And in those days in the 80s, they people stayed in for a long time. There wasn't a push to move people out of the hospital as fast. We had people in there for a long time, and you really had the opportunity to work with systems to see change in systems. So I never
Mhm.
really grew up under the guise of a regional approach. It was always systems for me. Um, our our clients who had brain injuries also had to go to the bathroom. They also had cardiac concerns. They had, muscle and limb and joint and everything. So it was that was just how I was that was just the world I grew up in was, the whole person and all of the things for the person and everything was had an eye on function. We did spend time talking about impairments. Of course, we did interventions on impairments, but it was mostly with the eye on function. How can we get this person to be as optimized as possible to re-enter the community, their social strata, their family, wherever it was that they were going to be part of after they left. Um, from there, and also my early state, from there, my early stages in that area was also working in the AIDS unit. So the pandemic before the
Mm.
pandemic.
Mhm.
And so all of those clients had very integrative stuff. I started in
Yeah.
ICU with them, and they went all the way to outpatient, those that survived. And,
Mhm.
a lot of years working on, just how to optimize somebody, after they've gone through that kind of upheaval in their life, with their own physiological concerns. But, again, there was a lot of pelvic health in there that, I didn't even know pelvic health was a thing
Yeah.
back then. To me, it was still like people had to go to the bathroom. I was very close to all the occupational therapists that I worked with because we were doing it all together. I could
Mhm.
fiddle with the arm, they could fiddle with the leg, and we could, our goal was just to get people going. From the rehab unit, I had the good fortune of moving over into academic medicine at LSU, and I was the director of the faculty practice, and that was my entree into there. And so all of the faculty would come in 1 day or 2 days a week and see clients, as well as have their obligations to the school, the students, and the students' education. We were moving into a master's program at that time. So there was a big push for me to get my master's degree, which I did through the school as I worked in the clinic. And it was very interesting clinic to be in because there were people with double PhDs that would come in for
Mhm.
therapy and people basically who were coming from a very, very low um, socioeconomic status. So
Mhm.
we had a wide diversity of people. And I'll remember the first time, and they talked about everybody as diagnoses, like, oh, you have two shoulders and a neck at 3 o'clock or something like that. And I always thought that was so weird. And the first time when, here I am and back in the world of orthopedics, which I didn't spend a lot of time in before. Anyway, this uh, gentleman walked in and, they told me he was going to be a shoulder patient. And all I could look at was how he was walking. And it was interesting to me because, yeah, his shoulder was hurting and this was going on. And it turned out to be a cervical problem. I remember that pretty clearly. Like he just had pain in the shoulder, but it was coming from the cervical spine.
Mhm.
But, it was all because of this. posture and control thing that he had going on. So his shoulder was constantly hiked up because he was loading the other side so much, and he had a twist. And it turns out they had this, pretty significant history of torticollis,
Mhm.
and that set him up for all of this other stuff. And so, yes, we treated the neck, but we treated, the whole system to see what we could do to help optimize him. And, at that time, it was kind of pretty clear to me that um, we have to look at all of these joint specific things within the context of the body. Uh, Not too long after that, in the um, mid 90s, Dr. Lewis Wall came into the office. He was working at LSU at the time before he moved on to St. Louis, and was looking. He came in and he said, "I need a physio." And for those of you who don't know, Dr. Wall is like the grandfather of Urogyne medicine. He wrote the original book. Anyway, he took me under his wing, brought me into his clinic, taught me everything he knows about everything that he was doing, what he was doing surgically, all the different things that he was doing, why people were having problems. And then he said, I'll start sending you clients. And I kind of just stood there, and he said, "You're a physio, figure it out." So off to the library I went and started looking up everything I could find. And I found a listserv through what was, at that time, we were the section on women's health, very
Mhm.
newly formed from being the OBGYN group through APTA. Got on the listserv so that I'll show you how old I am. Does
Good
anybody
old
else know what a
listservs.
listserv is? Like one big giant chat on a computer. But
Uh-huh.
got on the listserv so I could start reading and listening to everything that was going on. There were very few courses in those days, and if they were like a week long, and there was no way I could. I was I had a young child. I was a single mom, and there wasn't any way I could leave for like a week to go
Mhm.
off to a course at that time. So lucky for me, Fatima Hakim was just up the road in Baton Rouge and had come to the school every year to kind of talk a little bit about urinary incontinence. Um, so I called her and I said, I got to come help me. I've got to figure this out, and I don't want to recreate the wheel. So she came down. We actually put together a small course, but it was basically so that I could learn as much as I could from her. And she was a lifeline in those days, which was great. But really, the way that I learned my trade, the way that I learned the things that I do, the way that I learned my approach for clients, all came from them, the people in front of me, because I think my gift was a lack of knowing from a
Mhm.
course, because I had to rely on my clients to tell me what was going on,
Mhm.
and they directed their care. So I just sat there and listened, asked a lot of questions, got super curious, and just started to kind of think, what do we have here? What's going on here? What systems are in trouble? What do they need? And what is it that's going to be relevant to them? Because they didn't know why they were there either. They just knew that they were having problems. And of course, they were kind of like, this is all very interesting that we're going to be doing physical therapy for this. And it's like, well, muscle, bones, joints, nerves, they're all the same,
Yeah.
so we're just gonna do the best we can. Let's figure this out. So I had a number of clients that way. Then there was a small group of colorectal doctors in town that found out about me and started sending me clients. So I thought, okay, have the Eurogyne perspective. Now I'm getting everything from the back passage.
Mhm.
And so these clients started coming in the door and started listening to their stories. And I got on the phone with them and said, we need to talk. I need to find out some things here, because I wanted to understand what they were doing with their protocols, because they were all coming in with diagnosis of fecal incontinence, and they were all on Imodium protocols.
Mhm.
And I was like, okay, you've got to sit down and explain this to me. I've got to figure this out. Tell me where I can find resources. And so that's what sent me down the road to, through GI issues, because as I started learning more about what was happening with these other folks that were coming from the GI world, I started realizing that this was a main visceral driver behind the
Yeah.
pelvic pain. and bladder issue and incontinence world. And being able to put the 2 and 2 together was, amazing for me because it made a lot of sense, but it also helped my other clients immensely when they started realizing that their constipation, that their gas and bloating, that their GERD, all of these had large implications, not just on their, pelvic pain and their bladder issues, but in their whole body themselves,
Mhm.
joint issues, back issues, the skin issues, autoimmunities that people weren't talking about in those days, lots and lots of different things. And, so when people would say to me, "Oh, you can, just start teaching, when we're gonna send you some students." And it's like, "Okay, that's fine. Do they know what I do?" And they said, "Well, we're thinking that you could just teach them, some stuff around urinary incontinence, like the simple stuff." And I just like, kind of like started laughing going, "Oh, I used to be like that too." There isn't anything simple about anybody, so it's like,
No.
"Okay, well, I'll just teach them the systems approach and we'll move forward." After I left, LSU, we had the hurricane came through, Katrina,
Mhm.
and our best move was to exit. And, so the professor ended up with a job in the Pittsburgh area, and so we moved up there. And I worked at a big payer company for a while, UPMC, and it was great. I learned a lot more. There I was surrounded by other people who did the same type of work. We had, clinicians in multiple centers and group meetings and, lots of things, and, was able to create a residency program there for, people coming in post-university training to really, get immersed into pelvic health, and did that for a while, and then finally decided one day that I really wanted to have my own clinic. So, Rebecca Meehan and I got together. We knew each other through UPMC very well, and said it was time. So we wanted to do something very different. So we decided to open a concierge practice in a part of town that was going to give us the ability to unleash ourselves from the overburdening insurance companies and allow
Mhm.
clients to choose what they wanted and how to pursue their own health. And for us to also hook up with a lot of integrative providers in the area. So it was an amazing journey, and, we learned a lot. We learned a lot about business. We learned a lot about partnership. We learned a lot about, really finding out what our clients want. During my time when I was co-owner of Embody, I spent a lot of time wondering why people weren't getting better and wondering what I was doing, and I was examining how I was doing things, and I switched from doing education to storytelling. That was one huge thing that I did. And then the other thing that I did was I started asking them at the end of the hour that they so generously wanted to have with me, what their take home messages were. And that was probably the most frightening thing I've ever done in my career,
Mhm.
because the things that people said, I was like, "Oh my goodness, that's what they're walking out the door with? Where did I go wrong?" And then
Oh.
it caused me to like, okay, but clearly got to do some other things. So I kind of delved into the world on motivational interviewing and coaching and, healthcare coaching, and, really started learning and working with how do you empower the client, that it needs to,
Mhm.
intrinsic empowerment, which fit all the pain science stuff and interoception and all the other pieces. And it was like, oh, okay. So I finally realized that what clients needed was to tell their story and really tell their story. And I needed to really sit and listen. And so I got a whiteboard. I got a lot of colored, like, markers, and I just asked them to tell me everything. And as they did it, I would sit there with them and we'd like mark things down, the key words they would say, key pieces to the puzzle, a lot of different things. Eventually, I started handing them the whiteboard as they were telling their story so they could write their own stuff down. But what came out of making a shift like that was I would have all of this information. We were able to triangulate it together. But what came out of it was, where do you want to start?
Mhm.
What's
Yeah.
important to you?
Yeah.
I know all of these. Well, I need to do everything. And it's like, I get that, but we can only start. We got to have a starting point. We've got to
Yeah.
start somewhere. Where do you want it to be? But that kind of work there started the pathway towards turning the keys to the kingdom back over to them.
Mhm.
And because from the very moment they walk in the door, the chairs were side by side. There wasn't a chair in front of another chair. It was a partnership from the get-go, and it really helped because they learned in the very first time with me that they were going to be directing their care. My job was to help them keep the oars in the water,
Yeah.
but they're paddling the boat. They're making the direction. And I learned quickly that a lot of things with pattern recognition, what I thought people needed and what they should be doing, was not what they wanted at all. When I
Yeah.
let them really run the show, they s they really worked on, like, "This is the issue I'm having with trying to do the exercises. This is the issue I'm having with this." We were able to problem solve the obstacles and the barriers in their life towards their healthcare versus me being super prescriptive and handing them this and, like, explaining to them over and over again why it was so important that they do it. And the outcomes were so much better, but I will tell you, as a practitioner, the mantle of burden on my shoulders was lifted because I no longer was attached to outcomes. I no longer was fixing anyone, and, or the myth, the perception of fixing people. And, the most important thing of all was that, I was having so much more fun. I
Yeah.
was empowered again as a clinician. My clients were empowered, and so when the professor retired, it was time to sell my portion of the practice to my lovely partner, and then, I opened up my business now, which is, health and wellness coaching, and then I consult and work with other clinicians to empower them to become the best clinicians they can. And one of my missions is for healthcare workers to silence their inner critic, step out of imposter syndrome, and become the healer they've always wanted to be. So my outward facing work is towards women at the pinnacle of their life, which is the years of menopause where we live decades, being seen, heard, and living the life that they really, really want to live.
Yeah. Yeah. That's such a learning journey. You explain in so many points through each decade from the 70s forward, um, how much you were learning. And I think that's probably, I think, um, for whatever my opinion is worth, that to me is the most critical part of what keeps us alive and thriving is
Mhm,
curiosity,
mhm,
and continuing to learn and shift and say, hey, I can change my mind anytime. I can go left instead of right. I can, go up the stairs or down the stairs. And so that's what I'm hearing, from all that. And of course, your formative journey in helping us create the profession that we have now, in pelvic health and how far it's come. You guys who are listening, y'all don't know this, so I'm just telling you how great she is and how much influence she's had on so many clinicians. As a listener, what is your takeaway from listening to Susan's story? I know as a listener, mine is the point of curiosity. Mine is the point of wanting to feel empowered when I walk into an office, which I just did this morning because I before we press record. I actually physios need physio too, and
yes,
so the right out of the gate this morning, I was in PT.
mhm,
And when I walked in, I want to feel that sense of empowerment. I want to be able to ask a question and lead the session into the direction of, what's most critically impacting me, which usually is driven by pain or dysfunction or something where you're not able to do what you want. And so if you're listening, I want you to go into your therapy appointments with that high expectation that that's
mhm,
what you're supposed to get, because if you're not and you feel like um, your therapist is a sage on the stage instead of God on the side,
mhm.
you're missing something and you're missing something. So that's what I'm hearing out of your story. my next question is about, you've transitioned into this amazing kind of natural evolution that my evolution almost caused me to leave physical therapy because of
Mhm.
that's kind of a similar feeling of just being absolutely burned out and not being able to give people what they wanted. And so I broke away from the quote system, and into the integrative, took the integrative pathway a long time ago. Um,
Mhm.
and so I feel that journey that you have been on, because there's such a great deal of value to be able to step back and kind of do a quote kind of meta analysis, if you will, to get a little meta and step back and go, well, gosh, I don't like that. I don't like the way that's going, or I've changed my mind and I want to do something different. And so for you, you've gone from, again, like I said, this wonderful evolution where you have the freedom and the ability and the insight and the wisdom to step back and go, this is the direction I need to go now to harness, you know, the energy for your best life. Um, you mentioned that intersection, and there's such an intersectionality between pelvic health, when pelvic health was kind of like the front side of things and not the colorectal back side of things.
Mhm.
And then, I remember the first time that the gut microbiome, I was at a conference in Colorado where I was teaching on voice and pelvic floor and just basic stuff that had to do with yoga. It was very yoga driven. But anyway, someone was there. Her name was Dr. Sarah Gottfried. She is a
Mhm.
functional medicine OBGYN. She was there speaking at the same conference. And she presented research as well as another physician that her husband had done on the gut microbiome of neonates, and how vaginal birth versus C-section and all those things, it blew me away. That was brand new, right?
Mhm.
So now here we are knowing that everyone's heard gut microbiome, right? Everyone knows that things are connected and the stuff matters, but you know what? Not all practitioners are still recognizing that.
Right.
Um, so that's where the gaslighting comes in. And I have a personal story that, I'm telling you the story about way back in 14 years ago when I first heard the phrase gut microbiome. And I was like, wow, that just blew all my hair off. I'm going to think about things differently now. Um, Last year, I was in a physician's office and I said to them, I was just mentioning, some of the symptoms I was having, to which they said, which I knew they were wrong, but you just want to hear what practitioners are going to say. Are they going to validate, what we already know is true in the evidence base, which is pelvic pain and gut health are inextricably linked, right? They
Mhm.
matter, they go together. And so what I heard this physician say, and you already know what I'm going to say, is they said, and you can probably finish my sentence, oh, your gut health has nothing to do with, you know, gynecological health. And I was like, oh my God, I can't believe I'm still hearing this, right?
Mhm.
So
Yeah. That's a shame, isn't it?
it really is. And so I'm thinking, if I know that it's connected and I'm already like treating it. And anyway, long story short, for y'all that don't know the story, I went on to finally get a diagnosis of endometriosis, like so many women do, like decades late. Just simply because every time something would happen, they'd find a valid thing, but they were never really looking for root cause. Anyway, long story short, um, that was just yet another mile marker on the road that drove me towards dedicating this whole podcast toward ending medical gaslighting. Tell me about some of the stories, because I know you've got them. You've got a whole like suitcase treasure trove of the way women are gaslight around gut health and their pelvic health.
So yeah, there's a lot in there, and your story is very powerful. Just to piggyback on to the ending thing that you said was that my integrative work and my question, the way that I changed, my practice and the way that I kept growing as a clinician. Um, you talked a lot about patriarchy in your course that you did at Embody, and it was like, oh, that's something I'm not really thinking about a lot here. really digging into that a little bit more and top down. And I thought, I'm a really top down clinician. Wonder if what would happen if I wasn't as much as I thought I was, but I was.
Yeah.
My conformational bias was I was a manual therapist as well. And Anthony Lowe said to me one day, I wonder if what would happen, Susan, in his way that he talks, um, if you did a whole day of patient care and you didn't touch anybody. So it was like, okay, you're on. But it was good. It challenged my conformational bias that how much do I really need to put my hands on and how much do I really need to
Mhm.
listen?
Yeah.
So listening to stories is what we're talking about and what we're moving towards. One of the most distinct things that I think I've ever heard I mean, the largest intersection of group of people that I've ever heard that have the most similar stories, and there's many, many, but this is the one that stands out the most, is women who feel like they have nothing to say because they have entered a certain age.
Mm.
And they were probably and still are a big section of the most dismissed people I've ever seen in my life.
Yeah.
That we have one of the research things going down the GI rabbit hole, women more than men suffer from syndromes such as IBS,
Mhm.
and bloating and distension. They did a study, 89,000 American women, over 58% of them had these complaints. And out of those 58%, 49% would not speak to a healthcare
Oh.
provider about it.
Mm.
Wow, what does that tell us about what people are saying to them?
Yeah.
And the
A lot.
reasons that they gave was, "You're older, your system is slowed down, you just eat less,
Mhm.
don't worry about it, you're older." I mean, they keep saying that you're older, you're older, you're older.
Yeah.
So I started asking people what the word menopause means to them, and it doesn't have any kind of a happy connotation.
True. Yeah.
It just doesn't.
Mhm.
First of all, the word pause
Mm.
is a problem because that's the stem of the word. And, so it's like pausing from what? It's not a pause, it's a transition.
Yes.
So they don't understand that they're gonna live decades in this wonderful world of reproductive, not needing to be, I call it reproductive freedom in a way.
That's what I was
That
about to
they're no
say.
longer they're no longer having the physiology for reproducing
Mhm.
is no longer part of their
They're
life,
free.
right? It's a wonderful part of life,
Yeah.
but it's not. We lived without estrogen before, we can live without it again.
Yeah,
It just
the
takes the transition to do it, and so
mhm.
I would love to see I call it crossing the fiery bridge, because we have to have a physical or a physiological transformation in order to wake us up and move us forward to become the spiritual people that we were meant to be on this earth.
Yeah.
And we can't have that if we don't shed the other part. And so, but here's the thing, we need to shed the other part, but we don't need to be miserable because of it.
Right.
You don't need to be told, oh, just drink a glass of wine, it'll be fine. We don't need to be
Yes.
told that, just stop eating sugar.
Mhm.
Hey, don't worry, everybody goes through it, you'll get over it. We don't
There's
need,
there's a
the
big
brain
part,
fog piece especially, right?
yeah, of the history. And I think that to go back to that stat for a second, that half of the half wouldn't
Mhm,
speak to their doc about it. Um, I was just listening to a colleague who has her PhD in women's studies, specifically looking at women's health and the history of
mhm,
women's health in the US. And I think part of the reason is that there's this genetic, epigenetic ingraining, social conditioning that
mhm.
has us believing that we only have value if we're fertile.
Yeah,
And the fertility of women really, a lot of endometriosis care was based on that. just fertility, just managing
Mhm,
fertility. And
mhm,
without that fertility, then you didn't even need any treatment for endo anymore, which we know is not true. So I think that that shedding that you're talking about, that crossing the fiery bridge, we actually have to take off that coat that
mhm.
was put on us the day that we were born, that, oh, you have such value, you're beautiful, you're et cetera, et cetera, et cetera, until menopause, until you're not fertile anymore, and then you're paused, you're discarded, there's no value anymore. So if we just call, we can swear on this podcast, by the way, if we just say bullshit to that, right, and just shed the social conditioning, which is easier said than done, I think
Right.
that's a first step to know that, no, you have value, you have a voice. When you're crossing that bridge, that there's so much health and vibrancy there that has historically we've been fed a big fat lie that it doesn't exist, that you're supposed to have the aches and the pains and the leakage and all the stuff, when actually, no, you don't have to have that.
Yeah, and it's, I know a lot of people have talked about generational trauma,
Yes.
and I think
Mm-hmm.
that there's a in certain sectors, there's a ton of generational trauma because
Yeah.
it's not only been our grandmothers, it was our grandmothers' grandmothers and our grandmothers'
Mhm.
grandmothers before then and grandmothers' grandmothers before then. And forget it if you are a minority
Yes,
because
absolutely.
and it
That's
was
the
not only those stories, but the trauma that was induced upon women
mm-hmm.
in the name of learning and whatever other names we wanted to give it. So it's so much, but the thing is that I think the term becomes like almost like the expected, it's time for me to suffer. Suffer
Mm.
what?
Yeah.
Like, we don't need to suffer, we need to and we don't need to be silent. This is the thing when
Yeah.
people I hear this all the time, and I've experienced it, but when people, say to me like, "Well, they're not gonna really listen," and it's like, "Then we need to be effing louder."
That's right. And there are
We need to
mhm,
stop saying, "Well, they're not gonna hear me anyway, so I'm just gonna be quiet." No, we need to,
right.
like, pump up the volume and get nasty loud about it.
Right, and that
And
they're clinicians, and we're sitting here as two clinicians, but also as women who've been through it, to
Mhm,
say, nope, there are clinicians that care. There are clinicians that are going to help you with the evidence base that's out there, that aren't going to dismiss your gut health symptoms because they are related to what else is
mhm.
going in your pelvis, going on in your pelvis. So I think that's a big message of hope, for you guys. For all of us, really, is that yes, there is evidence, there is science, there are clinicians, there are people to help, and that's what we're here for, that's what we're talking about.
Right, and some of this stuff is so simple. This is what I'd love for everybody out there to really, really understand. You don't need fancy, fancy, fancy things all the time. If we can just really look, so to me, the idea of being on I call it the pinnacle of your life. I
Mm.
don't like to call it menopause anymore because nobody likes that word, so get rid of it. But when you're standing on the pinnacle of your own life, you have the ability to illuminate the corners and the crevices, so
Mm.
you can make some changes
I
that
love
can
that
be
imagery.
very, very, very powerful.
Love
And
that.
some of them may be something very simple, but maybe I need to just take 10 minutes to meditate every day or to do whatever spiritual practice I need. We do
Yeah.
something like that consistently every day. We have good evidence to show that our heart rate variability improves, which means
Mhm.
our general health improves.
Mhm.
If we
Pain
can,
decreases. Mhm.
yep,
Sleep improves. Yeah.
and if we can look at our circadian rhythms and get some sunshine in our eyeballs in the morning, we're going to have a bit of a better sleep at night.
Yeah.
We can turn a fan on at our desk. We don't have to suffer and be hot. There's a
I have a
lot of things
giant
we can.
fan next to my bed.
Exactly. We need to normalize this. We need to
Yes.
say that this is what's expected, that
Mhm.
this kind of self-care is not only expected, it's demanded,
Mhm.
and it's gonna come from us. So I'm partnering with everybody out there that I will help. I will do whatever I need to do to help us keep moving the message forward, because this is an absolute amazing time of your life where you can live for decades. And listen, some women enter this time way before their time. And I reach
Yes.
out to all of you
Mhm.
to know that you are not. dismissed because you no longer have the organs to be fertile, for
I'm taking
whatever
that.
reason.
I'm going to take that message personally because
Yeah.
I was one of those women to undergo that far earlier
Mhm.
than I should have,
Yeah.
in
And
part
it's,
because of mismanagement, medical
yeah.
mismanagement. That's devastating. I think any woman who goes through a surgical menopause,
Mhm.
especially when it was unnecessary, I don't know that there's a word that we could like just adequately describe that feeling and what it does. Yeah.
Mhm. But it's sudden, it's brutal, and
Yeah.
it needs care completely. The entire person needs care from the top to the bottom, and you talked a lot about the societal kind of blanket and the other
Mhm.
pieces as well. But, just to know that you don't need to feel this way.
Right, right.
There's
Shed the
support.
guilt.
Yeah, there's
Yeah.
support, and we need to if you can't find somebody who will support you, we will help you find somebody who will.
We will have that in the show notes, y'all. So just don't forget to
So,
read
yeah.
those as well.
Well, the other thing to consider is that, okay, the opportunity and gift of the pandemic, because there's gift and opportunity in everything. The
Mhm.
opportunity and gift of the pandemic is that we have broadened the world of being able to access advice, access care, access a lot of different things that we did not have possible before.
Mhm.
And we can really keep pushing that forward. So if you're somewhere where you don't have the kind of support that you want, we can help you get it. And there's a lot of places that will work with people,
Mhm.
you know, over telehealth and things, to help them maintain and get the care that they need and that they want so that they can feel their best to still
Yeah.
be this best person that they're on this earth to be.
Yeah. Absolutely. So let's talk a little bit about some kind of take home clinical
Sure.
pearls, or what we call in continuing education, y'all. We call them clinical pearls when you take home something that you're like, oh, I'm going to take that back into my practice and be better. But I want to talk about clinical pearls in terms of what you guys can do now. So,
Mhm.
if there obviously it is inexcusable if you go to a practitioner for pelvic pain and they tell you that the gut doesn't matter. It's wrong.
Mhm.
So we've established that. We can move on from that point.
Yep.
Now, like, what do we do specifically? What is a next step that someone can take when they are, there are resources for finding, physical therapists. Of course, obviously we'll have links in the show notes for that. But are there some specific clinical pearls that people can take home right now that, I think you and I, having been through this whole process already, can pick out a couple of the big kind of the symptoms that you would have related to gut health, what those are and what they can begin to think about, their treatment options are, because there are many, there's multifaceted.
Mhm. Yeah. So, the biggest thing is constipation,
Mm,
right?
yeah.
And everyone complains about it. We worry about it. I don't have a bowel movement. I don't feel good. What can I do? I don't, so I'll tell you there's a few very easy things you can do that can start to right the ship with whether you just have constipation or whether you have constipation and belly pain. The first thing, and it's so easy, is to chew your food as lovingly and as carefully and as holistically as you can possibly dream of, which means turn off the news,
Put your
which
phone down.
means put your phone down, which
Yeah.
means what's your favorite music, which means what are you putting your food on?
Mm.
Are you eating food on a paper plate with a
Mm.
plastic fork 'cause you're in a hurry and don't wanna do the dishes?
Or in the car.
Like, yeah, pull out your china, come on. China's not just for Easter, it's for, like, now. But anyway, present, make your food experience an experience again. And I get this out there, everybody always asks me, "How many times should somebody chew?" And the answer is 40. But here's the thing, no one's gonna count 40 chews. You will once, maybe twice,
Yeah.
maybe a third time some other time, but you're not gonna do it. It's
Yeah.
not really relevant. So I just tell people, here's the thing, slow it down, and here's how you slow it down. Put your fork down with every bite you take, or put your hand down with every sandwich bite you take.
Yeah.
Put
Yeah.
your soup bowl, that the spoon down with every bite you take, and be aware, just be aware of that. So again, it's just putting a little mindfulness on eating. But when we slow, and here's the reason why, when we slow down and we chew our food and we slow it down like this, like just even the pausing, you know, food in mouth, fork on plate, just is something you can teach your kids too. But when we do that and we slow it down, we actually are able to get the right kinds of enzymes from our saliva to start going down to the stomach. And when that happens, we get the stomach to be able to turn on the acid pumps and actually pulverize the food so that when it enters the small intestine, it's in the shape to do it.
Hmm.
When it enter and it also, when we eat slower, we actually can turn the GI system on lower because we have a reflex that tells us when we stretch our stomach, it tells everything down below that there's something incoming coming in, so it's easier to go and move your system after a meal. So that's like the number one thing, everybody's always thinking about what can I do down below, and to me, it's like start at the top.
Start at the top.
Start at the top, chew your food, and eat in such a way again, that just eat and really enjoy every bite. Then you're now, this is what makes this so lovely. You're getting a mindfulness practice in, you're optimizing your physiology for your whole GI system, and you're also increasing your opportunity to get those happy love hormones coming because you're doing it with gratitude. And,
Yeah.
so, and then it's kind of a training thing if you've got a family, like,
Hmm.
during this time, the nothing comes in here. This is our time to break bread together,
Yeah.
not to break knives together, to break bread
Yeah.
together.
And then
And
you can
Mhm,
also think about the carryover between the most important moment of the week from a psychology side. So if we're talking about psych-informed physical therapy and physiotherapy and
mhm,
pelvic health, is that for in psychotherapy, the most important moment of the week for your children and teenagers is a meal, right?
mhm,
And we have the opportunity to improve their mental health as well as their physiology just by setting that time aside. And I'm guilty of if I'm coming in between patients and a lunch, I will I'll do what a lot of us will do as clinicians, right?
mhm,
But which we shouldn't do. I'll answer a few emails and take a bite of my food and answer a few emails, or read this new paper that's out while I'm eating my lunch.
mhm,
So just there's a message in here for everyone.
mhm. The second thing that's so easy to do that everybody can access is some of the newest literature we have out about blood sugar regulation. And so we're
Mm,
talking about being in the pinnacle of your life, means, really making sure we have good metabolic health.
mhm,
And the best way to fight GI issues is to regulate your blood sugar.
mhm.
It
And
makes a
hormone
big
health.
difference.
Yeah.
Yeah, and your
Yeah.
hormone health for sure, like
Mhm,
for your night sweats and
mhm.
hot flashes and things like that that go on.
Yeah.
So here, how can I do this? Pick one meal, but usually it works the best after the evening meal. And after you eat, take a 5 to 7 minute walk. That's all you need to do. You wanna walk longer, fantastic. There's something about an evening constitutional that
Yes,
people
I
used
love
to
that
do
phrase. I love
because it helped them move their bowels better.
Yeah, I love that phrase. And my dog, who is actually sleeping on the sofa next to me right now, she needs her evening constitutional too.
Yes.
And there's really multiple levels of benefit to that.
So if the weather's bad, I live in the Upper Peninsula of Michigan on the Canadian border. The weather, so I get it. The weather's bad, it doesn't take anything to walk 5 minutes in your house.
Yeah, that's true.
You know, you're all most of you are already wearing some sort of wearable anyway, counting your steps.
True.
Just 5 to 7 minutes after a meal really keeps the blood sugar from spiking and makes your sleep better. When we sleep better, we actually get better digestion.
Yeah.
So, here's the third thing you can do for your GI. And you notice none of this is about food. about what I should eat or any of that stuff. That's
Right.
always comes later.
Yeah.
But the third thing that you can do is improve your deep sleep. And the best and most simple way to improve your deep sleep is optimize going to bed between 10 p.m. and before 1 a.m. I used to say 2, but you really need to get to bed before midnight. And
Yeah.
the reason being the circadian rhythms, whatever growth hormone we have left, which we still have, will drop in. But that's one of the big precursors to having a much better, deeper sleep. And when we have a deeper sleep, we have much better organ function and digestion.
Yeah.
So, as much as it's fun to watch that second or third binge show on Netflix,
Turn it
and you
off.
don't care because I don't have to get up in the morning with little kids anymore or whatever it may be, you really
Mhm.
should, you know, optimize your sleep by getting your eyes closed before midnight. And for
Absolutely.
people who
I
are
can.
younger with younger kids, get them to bed and get yourself to bed. Even if you have to get up in the middle of the night, optimize that sleep between 10 and 2 so that
Yeah.
if nothing else, you get 4 hours, you're gonna get some good deep sleep in those 4 hours, and that's gonna help along the way quite a bit.
Yeah. And I'll tell you guys, particularly with the last one, but all three of them, all three of the tips, if I, when I used to put the kids to bed when they were little and they're not anymore, now they're
Mm,
staying up past me when they shouldn't be. Um, I would put the kids to bed, and in effect, I was sleepy by the time I put them to bed because it's exhausting process to get young children to bed. I would actually just go straight to bed myself, and that gave me the 7 to 9 hours solid that I would need, unless they were when they were really small, and getting up. But that is the critical piece. If we can all get that good night's rest, and you wake up feeling like you can instead of like, I can't do this today.
yes, right,
Yeah.
because, if we don't sleep, we don't get a rise of the hormone that we need to think,
Hmm.
and that's called serotonin. Whether you know that or not doesn't matter. You need your thinking hormone, the one that helps you make good choices and like solves problems for you. When we're exhausted, more. We eat more food that's
Obviously.
fast and quick and processed that we all know. I don't need to preach any of that. Because our brain simply needs the sugar. So we have to take care of our brain if we're going to take care of our gut, because a happy brain is a happy gut, a happy gut is a happy brain. It goes both ways. So those are if you want three simple things to do, you start putting those into your life consistently. Message me and tell me how much better things are in a month, but it's got to be consistent. So you
Yes,
can't
I
pick
love
all
it.
three, pick one. Pick one and just really put it in and get it going. Then you can pick the next one and then you can grab the next one.
Awesome. Thank you so much.
You're so
Thank you so
welcome.
much for being on today. Tell everybody how they can find you, and we will also put it in the show notes.
Sure. You can find me. You can email me, Susan at ltiphysio.com. LTI is Learn, Think, Innovate. My website is ltiphysio.com. So it's all pretty easy to do. I'm available for consultations. I'm available for coaching. My coaching practice is for women who are crossing and have crossed the fiery bridge, standing on the pinnacle of their life. So happy to help in any way. You can find me on Instagram at and LinkedIn at at, at S Clinton PT.
Thank you.
Mm-hmm.
Thank you again, Dr. Clinton, for joining us today. And I cannot wait till the next time that I see you in person. I know we just saw each other
Mm-hmm.
at our annual PT meeting, which we call CSM. And one more clarity point, because you mentioned the professor twice, but I don't think most of our listeners know who that professor is. That
Yes.
is your.
The professor is my husband.
Mhm.
He was my second choice, which I chose wisely the second time around.
Very good.
Yes, but yeah, he's my husband and has been my partner since my time. I met him in New Orleans and we married in New Orleans before we left and moved to Pittsburgh and then to
Oh,
Michigan. So,
yeah.
mhm.
All right. Now that we've cleared that up, all right, y'all can go on with your mindful day of eating and get a good night's rest tonight. Thank you again.